Now I would like to hand over the mic to the chairpersons to start the session.
Everybody. We are going to start. A mixed bag 1. The first speaker is Dr. Mohammad Jamil. He will talk on how to write a scientific paper. Dr. Mohammad Jamil, please. Next in the line will be Approach to a Case of Dizziness by Dr. Nomal Mumin. And next will be Paradigm Shift in Diabetes Care from a glucocentric to cardiovascular approach by Dr. Jayanta Panda. So I request the speakers to be ready and Dr. Jamil will start the session. Please.
Thank you, sir. Thank you very much. A very good afternoon to all. So the topic that has been assigned to me is how to write a scientific paper. But why we write a scientific paper? For someone, it is just a curiosity. But for someone, it is a necessity that we have to write a scientific paper to progress in our academic career. And then while in this process of writing the paper, it's become the obsession for us to write more and more paper. And the stages at which we were, at the beginnings, it was more necessary to write on paper and we need mentor. But when we are about to retire, then it becomes the responsibility of us to mentor someone. So this process of writing the paper goes on. And it is needed to promote the better understanding and elaborate learning. And we must publish, as scientific information belongs to all mankind. If we know something, we must share with our peer group. And also to bring some positive changes in the practice and policy. So before we go to in details about the writing the scientific paper, the selection of journal is very important. Because many times what happens when we send some articles to some journals, it's straightforward it gets rejected. The reason is that we do not choose the right journals. So the failure to select the right journals leads to rejection and the wastage of the time. And we should also avoid the predatory journals. When we send any articles for the publication, we must check the following in the journals. The scope of the journals. Some journals accept the articles in the particular field only. So we should avoid sending unnecessary articles to that particular journal. We see the indexing of the journals, the impact factor, affiliation of the journal to the scientific society, then the accessibility, whether it is open access or we have to pay to get the full articles. Then time to print. Sometimes what happens, we send some articles to a journal, it gets accepted, but it takes time. Maybe it takes 2 years, 3 years to get published. Then the format of the journals at which we have to send the articles, then the publication charge. Many publications, now many journals, they charge money to get your article published. So the structure of the manuscript. So these are the headings. We have to remember the title, abstract, introduction, methods, results, discussion, conclusion, and some journals, they also include the reference as a part of the manuscript. So the title, how we write the titles. We should be very careful in writing the titles because it helps in searching our articles in the search engine. The way we write the titles, it should be very concise, it should be specific. If needed, we can put the place of the study. It should be neutral. It should not be interrogative, like what is the role of the dexamethasone in the tubercular meningitis? Or we should not be declarative, that the dexamethasone of 4 days is the best treatment for the tubercular meningitis. So we should avoid those terms. Example of one, the title is the adjuvant dexamethasone for the tubercular meningitis in HIV positive adult. Then When we write the titles at the time of planning the study, and later on we tailor after the completion of the study. Then some journals, they ask for running titles. The running titles should not be as long as the titles, but sometimes we give so that when we print the articles in the multiple pages, at the top, the left hand side, the running titles are written. Then choosing the keywords. It is very important because it's help in indexing purpose. It also helps when we search the articles in the search engine like the Google or maybe in the PubMed database or the Embase database. Then to choose the keywords, we should look for the variants of the terms like tuberculosis, then the cox, all these terms. And it is better if we search the medical subject heading database. This is the Medline database. There are lots of keywords you will get. You will get the repository of the keyword for individual diseases. Now coming to the abstract. Abstract, it should be written in such a way that when we see the titles, then we read the abstract, it promotes the readers to go through the whole articles. If the abstract is not written properly, nobody likes to continue reading. And the abstract is the part where the editor decides whether to accept this article for the publication or not. Most of the times, editors read only the abstract only, not the whole articles. Well, they found abstract is interesting, then they go for the whole manuscript. It is important for the selection of the paper and indexing. It should be concise statement of the major element of the paper. It should highlight the most important points. Usually, it is the last section to be written, but it appears as the first section in the articles. For the abstract, it may be structured with subheadings or unstructured without subheadings. Usually the 4 points are there. When it is structured like the background or the objectives, then the methodology or methods, results and conclusion. Discussion is not written in the abstract. So this is the example of the structured abstract, and this one is unstructured abstract. Now coming to the introductions. What we write in the introduction? The first things we write is what is known about this topic. What is there in the literature? For that, it is not the review of the literature. We cannot put all the review of the literature here. But we should mention what is known, what is lacking, what is the knowledge gap, and how we will fill up this gap, what is known and what is unknown. So while writing the abstract introduction, we must see what is known, what is lacking, and what is our aim to do, how to fill this communication gap or the knowledge gap. So what we start is the inverted pyramid. Start with the big things, then narrow down and try to find a research question, research hypothesis. The 2 or 3 paragraphs are there in the introduction. The first one is the introduction of the topic, what is known. The second paragraph, we usually highlighting the knowledge gap. And the third paragraph, we try to find out the objective and you write the hypothesis of the topic. Then there comes the methodology. It is the most vital part of the study and the manuscript. If we write the study protocol properly, it is just the copy of the study protocol. Everything is there in the study protocol of the thesis. So writing the methodology, just you can copy it and you can keep it here. The reporting guidelines are there. The different study have the different guidelines like the randomized trial, they have the consort, the observational study, the STROPES, the systemic review and meta-analysis, the PRISMA, the case report, the care. So there are guidelines to write the methodology. So the methodology, what are the things to be included? The study settings, where it is done, the place, the duration, study design, ethical consideration, the consent, the funding information, the trial registration. It is now a must. All the trials should be registered under the trial registry, and we have to mention here. Then the participation selection and the sampling, detail, the definition of the participation, how the sampling is done, the sampling methods, technique, inclusion criteria, exclusion criteria, sample size and calculation, then statistical analysis. We should not write the appropriate statistical analysis will be done. No, we have to write in the detail with the, if we are using some software, so we have to mention the name of the software, the license, then the year along with the version of the software like SPSS. Now coming to the result, here we narrate the information what we collected. There should not be any explanation or interpretation of the findings in the results. We only write the results only. Detail of statistics test to be included in the method, not in the results. Flow diagrams is very useful because it shapes the space, and for every journal, the space is very important. Then the sequence of these results are the description of this study object, demographic details, clinical characteristics, addressing the objective of the study, then the subgroup analysis. And we have to remember that the complete data should be provided in the result. We should not slice the result in multiple and we send the multiple papers. The table and figures. The table and text should be complementary. There should not be repetition. Whatever is written in the text should not appear in the table. What is there in the table should not appear. And the text and the table should not contain the same details, and they should be properly linked. The table should be complete. If you see the only table, it should be complete enough to get all the information. You do not have to go to the text. The figures, we have to choose the appropriate figure to be there. This is like the photograph, the pie chart, where to choose the pie chart, the bar diagram, the histogram, scattered plots, line plots, box plots, or the forest plots. Now, statistics. Many times what happens? We do the study, we have the data, then we ask, what statistics analysis we will do? No, it's not like that. We must have what the statistics to be done before the study or before the results. So what to do is decided in the study protocol, not after getting the results. Then the discussion. Here what we do is, we do the interpretation and highlight the importance of the results, what we did and what we found. We should always acknowledge the limitation and the strength of the study. We should discuss how the new information differ or support the already known. The focus on the primary outcome should be given much. Then clinical implication, what is going to happen after these results? So we must have a information that like whatever we got, whatever result we got, how is going to affect clinically. Whether there is any need of further research. Then at last, we write the conclusion, the take-home message. It should be a strong and concise statement and should address the objective of the study. Then the reference, one of the most important part of the study, because the proper reference means the proper study. It also avoid us to do the plagiarism. Referencing, if you put the proper reference, that shows that like, how much study we did on that particular topic. Always remember one thing is that when we write a reference, we should not include the references if we do not study the whole articles. Many times what happens, we study only the abstract and we put the references. No, this practice should not be done. We should always read the whole articles, because many times what happens, in the abstract something will be there, and later on we will see in the article something will be there. So the reference should be given only to the article that has been completely read. And the reference has two parts. That is, one is called the in-text citation and the bibliography, depending upon the style. Mostly now the Vancouver style is used, but there is one more system that is called the Harvard system. Vancouver means we enumerate like the 1, 2, 3, 4, and the last we do the bibliography, insert the bibliography in the numeric form. Here, the name of the author is given, and later on, in alphabetical manner, we list the bibliography. And these different journals, depending upon the source of the information, whether it is from the book or from the journals or from the conference proceeding, we should follow the referencing format. And the last, the ethical issues. The most important one is the plagiarism. So there are different forms of plagiarisms. The plagiarism basically means kidnapping. So to avoid the plagiarisms, there are the plagiarism check software. Once you complete the articles, when you complete the writing of the articles, it is a good practice to challenge these articles for the plagiarism check. Now the softwares like Turnitin is there. We use Authenticate software to check the plagiarism. Then comes to the conflict of interest. Then the salami slicing. Salami slicing means for the same study, the big result, we slice in multiple way and we publish in multiple journals. So this practice is not accepted. Then the authorship criteria, we all know that what are the authorship criteria we should avoid. Gift author, ghost author, then this gift author, ghost author, then there are many types of the authorship problem is there. So with this, I'd like to conclude my presentation. Thank you.
Your talk within the time. And I presume that each of us physicians have a lot of data, but we are not able to present it in a scientific way. With this, your presentation, I think all other physicians will be encouraged to do a scientific study. So now I ask our colleague to introduce the next speaker.
Very good afternoon. And it's a pleasant moment and very good time for us today. A very exceptional agenda kept by the organizers. I thank the organizers from the core of my heart, because it's a mixed bag. In the same time, scholars, the brilliant physicians, teachers, and also today, exceptionally, we have included a very renowned personality in the form of legislator. He's a presently sitting legislator of Assam Legislative Assembly, and he is a deputy speaker. Earlier also he was a deputy speaker, and great and an excellent physician in the same time. I take my all privilege and pride to welcome Dr. Nomal Momin, please. And in the same time, I assure all the audience, be ready with the questions, because I give all the liberty to grill him today like anything. Thank you, Nomal, for making your time. Thank you very much. And his topic is a very interesting topic. It's on dizziness. And next few minutes will be all yours, Dr. Nomal Momin.
Very good afternoon to you all, respected chairpersons, all my beloved teachers, senior and juniors. And today, actually, I came here after so much of insistence from Dr. Dijandas. And I accepted his invitation. And when I accept his invitation, he again insisted to present a topic here. I told him that 7.5 years I'm out of this touch. But as you are insisting, I will come just to show myself as a celebrity, not as a clinician. I'm here not to give so much academic input to you, but I came here to boost up your morale today. And I must congratulate all the physicians of Assam who get together here. And this is the platform which the medicine of our academics we get here. So without further delay, I will try to touch my topic very promptly, but whatever you don't understand, go home and study properly, then you try to understand. Because whatever question is there, one of you asked, then another you helped to answer it. So liberty as given by Dr. Langtasa, because it is a great day. One medicine specialist is a turned politician, is a chairperson. Another medicine specialist is presenting this topic. Very good afternoon to all of you. This approach to a patient with dizziness. So in our outdoor, we frequently encounter with a patient with this dizziness. Dizziness refers to the abnormal sensations related to perception of the body's relationship to space. And there is 4 types: vertigo, presyncope, lightheadedness, and disequilibrium. So there is peripheral and central causes are there, our system is there. So this anatomy and physiology, if you study well, so this entire vertigo is related to this organ, vestibulocochlear. Then we have vestibular nucleus plus this cranial nerve, 3rd, 4th, 6th, and vestibulocochlear. Of course, cerebellum, spinal cord, cerebral cortex, that superior temporal region is the main area where this vertigo is related. Then spatial oriental and posture. This related to vestibular, somatosensory, visual. If any imbalance here, so we may have a vertigo. Slide may not be very nice one because just pathophysiology of vertigo and nystagmus. We all know that any imbalance between the vestibular cochlear system and the periphery nervous system, which may lead to this one vertigo. So nystagmus, which we get a objective component of vertigo, and which in clinical examinations we find it. Nystagmus we may get spontaneous and positional. This positional is we may get doing maneuver. So I'll come later on where we do this maneuver. That a patient which come to your clinics, so you have to take very meticulously take history. So history is very important. Sometimes we may have a patient with a vertigo that he has a travel with the flight and also sea diver, because in Assam we don't get sea diver. So that also causes vertigo sometimes. Then, so this detailed history is important. So sometimes viral infection, the fever history is there. Sometimes ear discharge, that also you have to take the history because it is related to the vertigo, and I'll come to that point. And one most important is the cardiovascular diseases. And in CVA, we have to take meticulous history, the history of smoking, history of alcohol, or any drugs he is taking for like antihypertensive, this history, you must take meticulously so that it can help you to diagnose your vertigo cases. So this history, the peripheral vertigo associated with this one nausea, vomiting, hearing loss, and triggers during change in position like upper respiratory tract infection also, stress. Those are the history you have to take. Then loud noise, which can precipitate vertigo. That was first introduced and discovered by Professor Petrio Tullio, biologist from Italy, and he experienced this phenomenon with a pigeon when he was trying to hold a wall with a drill. That time causes noise, and that time we noticed that pigeon has got some kind of vertigo and fell down. Then he tried later on, then this phenomenon is after him because of the noise also sometimes can have this one vertigo. Then pre-lymphatic fistula in trauma cases, because trauma also you have to take history because temporal bone injury can lead to destruction of the vestibulocochlear system that may lead to your vertigo also. So then Meniere's disease also there, and benign paroxysmal positional vertigo, that is also you have to take frequent head moving up and down that causes this BPPV, and vestibular neuritis. And in these two conditions, benign paroxysmal positional vertigo and vestibular neuritis, they don't have your hearing loss, but labyrinthitis and Meniere's disease, they come with your hearing loss. Then dizziness, you all know that this non-rotational and rotational, then you may have this one non-rotational, you may have pre-syncope, disequilibrium, lightheadedness, and they are rotational, it is central nervous system, neurological symptoms, and vascular risk factor. I already told that the cardiovascular system we have to do. Sometimes intracranial tumor and the infection, I already mentioned that may lead to the dizziness. And peripheral, you may have tinnitus, hearing loss, and nystagmus, nausea. This again, Meniere disease, labyrinthitis, vestibular neuritis, and benign paroxysmal positional vertigo. Then physical examination, you have to be very careful while examining the ear. So any ear discharge or any vesicle, particularly in the herpes zoster infection, that viral also causes vestibular neuritis because of the autoimmune origin. So we have to examine very properly this your external ear. Then we know that one maneuver, if you put the tegus, if tympanic membrane is torn up, then there is perforation, then you may have nystagmus also and vertigo also. So neurological examination is very important. So this coordination, Romberg sign, and then heel to toe test. Our Greenwood sir is there. He taught us very well in the clinical classes. So we still remember sir's classical teaching. So those your examinations, particularly those vertigo, may lead to diagnosis if you do proper examination. And cardiovascular examination is very essential. Pulse, BP, you have to heart rate and rhythm is very important. Sometimes cardiological cause, heart block also there. You can clinically assess if there is some problem, then it further leads to further investigation of the cases. So, of course, carotid bruit also we have to see to rule out cardiovascular diseases. Then how you differentiate with different causes. So labyrinthitis onset is very few seconds to minutes. Then provoking factor is change in head position. Then special phases you will get tinnitus. Then hearing loss is present in labyrinthitis. Vestibular neuritis. In the vestibular neuritis and labyrinthitis, the difference is there. You may get hearing loss here, but there is no hearing loss here. And benign paroxysmal postural vertigo, it comes into second. And change in head position, you will get this provoking factor. And positional also, you may have this special pressure. You change the position, you may get this vertigo. Then positive disc helix test. We know, I think, ENT classes, we can remember disc helix test. Patient put 45 degree, sitting in the position with a 45 degree, his face is turned, and suddenly lie him in the bed, and ear faces towards the surface, ground. Then he will, 1 to 2 minutes later, he may develop nystagmus. Then it is benign paroxysmal positional vertigo. The Meniere's disease, we all know that it is unknown etiology. Most commonly, females above 60 years is sufferer. Then this benign positional vertigo, this already I told, rapid change in position of the head. Recurrence is common. Diagnosis by disc helix test. Simple clinical examination, you can have distinguish this benign paroxysmal postural vertigo. Treatment is this only if least maneuver. So acute labyrinthitis, you have to take history. This inner ear membranous and body labyrinth is involved, present with vertigo and hearing loss preceded by viral infection. This viral infection, that's why you have to take a history of fever. So that's why viral fever, it is most commonly we encounter in this one, acute labyrinthitis. Main diagnosis factor of ABP is hearing loss, here labyrinthitis. Meniere disease. Meniere disease already I told, then there is much known about Meniere disease. So it is above 60 years female, they are involved. And permanent hearing loss also you may have in this Meniere disease. Then vestibular sedation, loss all diet, diuretics, this can be tried or a surgical correction in Meniere disease without any much success. Vestibular neuritis, again I told that history of upper respiratory tract infection or herpes zoster, these infections, you have to take history, and the examination also you have to take properly. Then investigation, of course, blood sugar, this is related to cardiovascular disease, other parameters of dyslipidemia and all, kidney function tests you have to do, and hemoglobin also you can set. That if required, if injury is there, then definitely we may have CT scan to rule out intracranial lesion. We must go for MRI lesion, and proper cardiovascular examination is required if cause is not evaluated properly. Neurological sign symptom, this definitely we have to examine. Treatment actually, according to symptom, according to the cause of the disease, if trauma is there, correct this. And beta histine we can use because it is commonly used. Bhartin, all physicians is very much fond of this beta histine. But one thing is benzodiazepine. If epileptic patient is taking this group of drugs, so it should be avoided because this benzodiazepine causes more precipitation of the vertigo. Lifestyle changes, obviously it is required in every disease, not only in vertigo. So other surgical intervention also may be required according to the diagnosis. So thank you very much for the patient sharing. But again, I am telling that I am not putting so much academically, but I came here only to meet my teachers, my friends, and to boost up your morale. Thank you very much for patient sharing.
Thank you, Dr. Momin, for an excellent presentation. I'm happy that you still remember all those tests and clinical examination of the patients. Please be seated. And especially thanks for making time to attend this session. Thank you very much. Now I pass to my co-chairperson.
Thank you, Dr. Momin, once again. So we are going to have our third speaker. So I would like to invite to the dais Dr. Jayanta Panda. He is from Odisha. He is known to all of us, and he is a very good orator, academician, and a renowned physician. So he will speak on paradigm shift in diabetes care from a glucocentric to cardiometabolic approach. Dr. Panda, please.
Good afternoon, everyone. Most respected the chairpersons, my esteemed delegates of this 32nd APICON Assam in beautiful place of Tezpur, and all who matter for API, matter for science, matter for all of us around. I am proud to be here, and because of the paucity of the time, I'll be very brief, and this presentation will be a continuation of the great oration delivered by Professor A.K. Das, my mentor, in relation to the paradigm shift and the metabolic challenge around. Before that, I must appreciate the scientific committee's work of designing such a beautiful program, and especially keeping the theme of preserving tender touch. In the digital era, in the digital medicine, we are gradually losing tender touch, and anybody goes with a list of investigations and big list of medications. After COVID especially, hardly a physician touches a patient. That has to be restored, and the great teachers who have taught us that inspection, palpation, percussion, auscultation should never be forgotten in clinical medicine. So in paradigm shift in the diabetes care, in the next, say, 13 minutes, I'll tell you about the glucocentric to the cardiometabolic approach. All of you agree that we wanted to bring down the blood glucose for last few decades of our patient, as a part of the diabetes management. But it's time to go beyond. Bringing down blood glucose will not suffice. So thank you, Team Tezpur. I'll tell you the burden of CBD, how weight can further complicate. Professor Das has already told benefit of the weight lowering and the CBD protection and drugs that provide a holistic approach. All of you know that 11.3% is the burden of cardiovascular diseases, and the CVD affects 7.8% of the adult population. And if you compound the diabetes and the CVD together, the ICMR INDIAB data already shown to you that with a prevalence of 11.3% diabetes and 7.8% cardiovascular comorbidity, it comes around 34.8%. 34.8% CVD affection in the patients who are having diabetes. So in 2030, it's projected to be still more, and you have the numericals in the below. And you know the CV complications, almost more than 50% in our patients, is 53% unstable angina, 54% myocardial infarction, 56% heart failure, and as high as 72% are the stroke. And you will see this picture, you can know CVD was the cause of death in 2 out of 3 people with diabetes more than 65 years. And in an average, at the age of 60 years of life expectancy, it's reduced by 12 years for a person with diabetes who has experienced a heart attack or stroke. 50% of death in population with diabetic attributed to CVD, and 85% deaths from CVD are due to atherosclerotic cardiovascular disease, including heart attack and the stroke. And with this data, with macrovascular complications and all the possible complications even at the point of diagnosis, almost every 8 seconds a diabetic dies of the complications. Here, let us see the economic implications of the diabetes and the CVD. And here it clearly shows for a 1% rise in A1C, there is 17% increase in the incidence of CB events. And almost the budget of managing the diabetic with the CV complications becomes double when the A1C is more than 7. You can see here from 1% how it has become 1.85%. Here you can see the annual total healthcare cost in diabetes and CVD are 4 times more than the people with diabetes only. And this includes the pharmacy cost, the outpatient cost, and the inpatient cost total. So if we have an added CVD, the budget becomes 4 times more. And the further worsened with the increased weight, which has already been touched upon in our oration. The weight promotes cardiovascular disease via multiple mechanisms. You know, when diabetes, CVD, and the obesity are combined, the blood pressure, blood glucose, insulin resistance, lipids, and inflammation all go high, taking care of atherosclerosis, thrombosis, myocardial infarction, stroke, and peripheral vascular disease. So the connection between diabetes, obesity, and the CVD, if you'll see, the people in the society with inadequate blood glucose control are 77%, and overweight and the obesity are 88%, and the cardiovascular burden is almost more than 70%. And taking all together, the morbidity becomes very high, and our people succumb to the complications. In the hypertension, diabetes, dyslipidemia, there is more than 24% higher in those who are overweight or obesity. You can see here the people with hypertension, people with diabetes, and people with both. And if you combine both, the mortality and morbidity becomes compounded with all these risk factors and the death rate increases. So people with coronary heart disease and the people with cardiovascular comorbidity, if in overweight, which is 27 and 24%, becomes almost double the 49 and 44% if they go to the category of obesity. And 50%, half of the people with obesity are with increased risk of coronary heart disease. So here the overweight or the obesity is associated with the increased risk of the coronary syndrome as well as the heart failure, and you can see this big trials which all endorse this data. So diabetes and obesity together increase the risk of all-cause mortality by 7-fold. Many times we don't know, we don't intervene, and let us know how many of us are active in intervening the data. Let us come to the drugs that we use. The sulfonylureas that we use in almost many patients along with the metformin, and metformin is assessed to be used in as high as 86.6% of the population. Next, gliptin comes in 53.1%, insulin in 17.2%, and the DPP-4 inhibitors are in patients of 25.8%. And if you see the SGLT2 inhibitor, it's used in 4.3%, and the GLP-1 receptor agonist hardly used. I don't know how many of you will agree to me, but our awareness in choosing these drugs are very poor, and even good drugs like glitazone has a 10% cell. And then you can know that the diabetes seems to conform 3 to 4 times higher risk of cardiovascular disease to the Asian Indians. Still, while choosing an anti-diabetic drug, hardly we consider drugs with cardiovascular benefit. So all these data together tell us that we should extrapolate the drug more at the time of diagnosis. So here the benefits of the glycemic control and the weight loss in the CVD I'll touch upon before I tell. From all landmark trials, the DCCT, UKPDS, the treat early and treat to target for microvascular benefits, Accord Advance and VADT, the age-old trial we all have seen, individualize the target A1C, avoid harmful severe outcomes. ADIC and post UKPDS tell the macrovascular benefit will manifest only after the long-term treatment after a early state. So the amount of the weight loss, if it is up to 5%, we get benefit for hypertension and the hypoglycemia, 10% prevention of diabetes, NAFLD, PCOS and dyslipidemia, 15% the cardiovascular disease, the urinary stress incontinence, the NASH, osteoarthritis, reflux diseases and sleep apnea, and if it is more than 15%, we can expect up to the remission of diabetes, CV mortality and heart failure with preserved ejection fraction benefits. So the weight loss provides positive health outcome directly being proportionally related to the weight loss. And the look ahead trial clearly tells the more than 10% weight loss, the overall study population who have gained, it all favors the weight loss. 10% loss in the diabetic and obesity has 21% low risk of composite outcome in a time of 1 year. So weight loss results in cost saving, which doubles when weight loss increases from 5% to 10%. You can see here, if 5% weight loss is there, if you save around $4,800, if it becomes 10%, you are saving up to $8,700. And this cost saving associated with weight loss are greater in the people with higher starting BMI. So with this, not only the cost, not only the cardiovascular protection, our quality of life, if you take a scale of measuring the quality of life, it improves. In a 1 kg per meter square decrease in the BMI, there is almost 0.0171 improvement in the quality of life. So we modify CV risk in diabetes. How? we know that we have to stress upon lifestyle, anti-inflammatory therapy, weight management, platelet inhibition, management of dyslipidemia, and glycemic control. And if you see the weight of the different drugs on weight, there are weight neutral drugs like metformin, that there are weight enhancing drugs like sulfonylurea and glitazone as well as insulin, and there are weight reducing drugs like SGL2 inhibitors and GLP-1 agonists, already told by Professor Ashok Das. And if you see the benefit very quickly on the heart, this is the GLP-1 receptor agonist, which I consider as the best anti-diabetic drug at present available on globe and mostly unused by all of us. You can see the benefit on heart, the multiple benefit, decreasing inflammation, ischemic injury, increasing the glucose uptake, LV function, and the heart rate, and the on vessels, the vasodilating, plaque stability, blood flow, and the endothelial function, decreasing inflammation, smooth muscle proliferation, and platelet aggregation. Similarly, if you will see the SGL2 inhibitor, there are multiple benefits through different means in the heart as well as the vessels. And you know the direct effects that like improving endothelial functions, decreasing vascular smooth muscle activation, decreasing vascular inflammation, all lead to blood pressure, weight, and A1C reduction. So GLP-1 receptor agonists work beyond glycemic control for atherosclerotic cardiovascular disease risk modification that all of us know. So if you see all this group of drug, the SGL2 inhibitor and GLP-1 receptor agonist only have the effect of weight reducing and the cardiovascular benefit. So as per the guideline, it's not required that we'll go for metformin after lifestyle, go on adding 1 drug, 2 drug, or 3 drug. Depending on the early atherosclerotic cardiovascular disease or the diabetic kidney disease or the obesity, we can choose our drugs and move on. So with this, I'll conclude. The diabetes increases the risk of CV complication by more than 50%, and the incidence of CV events almost doubles as A1C increases beyond 7%, and 10% of the weight loss in the diabetes and obesity has a 21% low risk of a composite outcome within 1 year. So with this, I want to know how many of you will wait till your patient develops a CV event, or right from the diagnosis with CVD and the obesity will start drugs with cardiovascular benefit. Please raise your hand. So I think there are a good number of physicians who are convinced. With this, I thank all of you for the attention and the organizing committee for this wonderful opportunity. Thank you all.
Thank you, Dr. Panda. You have nicely described the benefit of cardiovascular protection in the diabetic patient. For any oral anti-diabetic, I think that one should be ideal drug should be which reduces the HbA1c reduction very nicely and have a very good cardiovascular protection, also a renal protection, and above all, it should be a cheap drug. So there GLP-1 receptor agonists are definitely expensive drugs. So session is open for discussion, and we can invite 1 or 2 questions.
Sir, this is my question to Jayant Panda, sir.
Yes, sir.
Sir, in the recent 2023 ESC and ESH guidelines, the non-steroidal mineralocorticoid receptor agonist, phenytoin, has been advocated to reduce the CV events and renal diseases, and also hospitalization for heart failure. So where do you find, in this context, the importance of phenytoins?
Yeah, very rightly told. That has been come to the purview of the cardiorenal protection, and I'm sure more studies are required in the Indian population as well for the benefit, because it's already available, and we have started extrapolating for in Indian patients. It's wise to again utilize this drug early for the benefit of the heart and the kidney. But we need more studies in the Indian patients to give support to that particular recommendation.
Is Dr. Zaidis here? Dr. Jamil, please. Please. Any other questions from the audience? I gave all the liberties. No question to our legislator. Anyway, please. I think if there is no more questions, and the time is for the lunch, and our legislator is also a very busy person. We have to leave him. And with a lot of thanks to the organizers and a lot of thanks to all the honorable speakers, we would like to conclude the session here. Thank you very much.
Thank you so much, respected faculties. May I ask you to please pose for a photograph, sir? Please. Can I have your attention, please? Now we'll be breaking for lunch. And I must thank everyone for the excellent time management, for adhering to the time. So, and we are totally in schedule. I am very proud to say that. We'll restart the session from 2:45. So I request everyone to be seated in the hall by 2:40.